My name is Emiliana Iliayi. I'm a journalist, a gender advocate, and one that is very interested in women's health as well as girls' education, girls' support. I did an interview recently, and one lady battled with infertility stigma. It happened that she suffered a condition, a medical condition called polycystic ovarian syndrome, PCOS for short. And we had that interview. Today, I'm here with Dr. Samuel Gyedu Owusu of the LEKMA Hospital. He's going to give us a medical perspective of PCOS. If you are not suffering this condition, you might know somebody who is. Pay attention to this interview, to this conversation, and then share with people you think will benefit from it. Thank you. So, welcome, Dr. Samuel Gyedu Owusu.
Thank you very much.
So, we are here today to talk about polycystic ovarian syndrome. We want the medical aspect of it. So please tell us, Doc, what is polycystic ovarian syndrome to the man on the street, the layman on the street, who doesn't have any medical knowledge, any medical background?
All right. So when we talk about PCOS, that is polycystic ovarian syndrome. As the name implies, it's a syndrome but not a disease. When we say a disease, it means it has a definite cause. But when we talk about syndrome, it's a cluster of symptoms or etiologies. So we have several things coming together to cause that particular condition. So that is polycystic ovarian syndrome. Now, it's a dysregulation between the hormones of the female. Normally, we have the central, let's say the central government of the body being the brain. The brain, one part of the brain called the hypothalamus, secretes a hormone. That hormone is called the gonadotropin releasing hormone. Today we are going to use some big words, but pardon me, I'll try as much as possible to break it down to the level that the layman can understand. So in the normal cycle of a woman, the woman undergoes ovulation, menstruation, ovulation, menstruation. If along the way there is an introduction of a sperm and the egg meets the sperm, there is pregnancy. Now, the central part of the body, that is the brain, one part called hypothalamus secretes the gonadotropin releasing hormone. And that gonadotropin releasing hormone also is sent to another part of the brain called the pituitary gland. And it also secretes something we call the follicular stimulating hormone. So we now hear two big words: follicular stimulating hormone, gonadotropin releasing hormone. And I'll add another one being the luteinizing hormone. The most important hormone here that we are interested in is the follicular stimulating hormone. Why are we interested in that? The female system, the reproductive system, comprises of the fallopian tube, the ovaries, and the uterus. The ovaries, inside the ovaries, we have follicles, and inside these follicles, we have eggs. So if you hear the name follicular stimulating hormone, it means it stimulates the follicles. Now, this hormone gets to the ovaries, stimulates the follicles, and during ovulation, you will see that about 12 to 20 follicles will be stimulated. That is the normal cycle of every female. About 12 to 20 follicles will be stimulated. Now, when these follicles are stimulated, they now start to release the main sex hormone of the female, that is the estrogen. I hope for that one we've heard it over and over again, estrogen. Now, this estrogen tries to go into the bloodstream, goes back into the brain, then we call something a feedback mechanism. It tells the brain that, oh, it's okay, I've had enough of the gonadotropin releasing hormone, I've had enough of the follicular stimulating hormone, so stop. I'm okay with it. Immediately it sends this signal, the brain stops producing extra follicular stimulating hormone. Now it switches on to a luteinizing hormone. You remember I said follicular stimulating and luteinizing hormone. The follicular stimulating is more in females because they need that for ovulation. But the luteinizing hormone, under normal circumstances, is not a lot because that luteinizing hormone produces hormones that are not needed in the female, that is testosterone, androgens. They are more needed in males than in females.
But do females have it?
Yes, they have androgens, they have testosterone in few amounts. It's not a lot because they don't need it for their functioning. God made it in such a way that they have it in a low amount, then they have the FSH, that's the follicular stimulating hormone, in high amount. So if you have a situation where a female is having more of the luteinizing hormone than the follicular stimulating hormone, that female starts to express male features.
Okay.
Do you get it?
Yes.
So that is why most of the time you see some women with male features. For example, hairs around their upper lips, they have beards, they have hairs on their chest, they have hairs on their upper abdomen, they have hairs on their back, like features more of a male.
Thank you, Doc, for that point. So I want to ask you, does it mean that every woman you see on the street with hairs on the chest, beard, sometimes even mustache, does it mean that automatically they have PCOS?
No, that is not true. So, hirsutism is a term that we use to classify people with excess hair growth. At the same time, we have something we call hypertrichosis. It's also excessive hair, but in order to correlate hirsutism, then we usually correlate hirsutism with polycystic ovarian syndrome. So it's a cluster of symptoms. In the same way, you have to also differentiate it from vellus hair. In our local dialect, sometimes we call it inkwumi, like the fine, sparsely distributed hair that initially comes before the coarse ones come. Do you get it?
On which part of the body?
Oh, it can occur in the armpit, it can occur around the upper lip, that's the mustache, it can occur. So when every adolescent starts to develop hair, they usually start with the vellus hair, that's the sparsely distributed hair. Then later they become men. That is when they have the coarsely distributed hair. So if you see someone outside having a lot of hairs around, a female in particular, having mustache, having beard, having a lot of hairs on the arms, on the legs, it doesn't mean this patient has hirsutism. It means that this patient has hypertrichosis, that is excessive production of hair. It may be natural that this patient is hairy.
It doesn't pose any medical risk?
It doesn't pose any medical indication if it's not hirsutism. So in order to say someone has hirsutism, then you have to prove further.
Okay. Okay, thank you. So, the woman I spoke with started menstruating at the age of 15. Yes, and to her, she wasn't alarmed because she didn't know she even had that condition. So I want to find out from you, if you delay, we know that scientifically a woman should start menstruating at 13. So what's the implications if you have a delayed menstruation that start at 15 years?
Okay, so usually a female is supposed to start menstruation around 13 years. We've had situations where females start at 9 years, 10 years, and some also start later at 17, 18 years. If a child has a delayed menstruation, then you have to send the child to the hospital and find out what may be going on, because it's not usual, it's not normal for someone to delay till 18 years, 17 years before the person starts to menstruate. So you shouldn't stay home and be like, oh, it will come, let me wait a while, it will come, let me wait a while. We make that mistake, then along the line when the child grows, she has no idea about what she's going through, and she has no one to speak to, because when she was young, nothing was done about her condition. So it's better if you have a girl child at 13 years, 14 years, 15 years, and menstruation has not set in. It has to call for alarm, then you go to the hospital for further investigation.
Okay. So does it also mean that once you delay, your menses delay automatically, or there is a propensity that you have
No.
PCOS?
No. We have so many conditions contributing to abnormal menstrual cycle or menstrual irregularity other than PCOS. The PCO part of the PCOS is called polycystic ovaries. Without the cluster of symptoms that we will later talk about, it's not a syndrome. So a child may have an ovarian cyst. Ovarian cyst may cause an irregularity in the menstrual cycle. The child may have polycystic ovaries without the syndrome, just polycystic ovaries. It may cause irregularities in the menstrual cycle. It doesn't mean that this child has a PCOS. So menstrual irregularity is not always linked to PCOS.
Okay, Doc. Thank you very much. I want you to touch on some of the symptoms that when you see in your body, you know that, hey, I have this condition and I need to get to see the doctor.
Okay. So in the medical line of our line of work, we have something we call the Rotterdam criteria that we use to diagnose patients with PCOS. It has three main aspects. One, we have something we call hyperandrogenism. Hyperandrogenism, if you say something is hyper, it means it's more or it's high. And if you say androgen, it's one of the hormones that we earlier talked about, that I said is more in males than in females. So if you have a female having hyperandrogenism, it means that the female is having more of a hormone that is supposed to be in a male. Now, this hyperandrogenism is characterized by hirsutism, that is, the excessive growth of hair around the upper lip, that is the mustache, the beard, the chest, upper part of the abdomen, the upper back, the lower back. These are the main points where people with hirsutism have their excessive growth of hair. Second thing is acne. We usually call that type of acne treatment-resistant acne. So you'll be using a whole lot of topical creams, ointments, but this acne is not resolving. It's part of the signs of hyperandrogenism. So hyperandrogenism is one part of the criteria. The second part is oligo or anovulation. That is the infertility aspect of things. The oligomenorrhea means that usually you are supposed to have 12 menstrual cycles in a year, because every month you menstruate.
Yes.
So technically you are supposed to get 12 menstrual cycles. If someone gets lower than 8, it means that this patient is having oligomenorrhea. Some people may not even have menstrual cycle for over 5 months because they are not ovulating. If you're not ovulating, then it means that you're not producing any egg. Then it means that even if you have sex, there is no egg to meet the sperm. Then it means that you will not be able to give birth. That is the infertility aspect out of things. Then, if you have the oligomenorrhea, it means that your menstrual period is irregular. So, since it's irregular, even in the normal regular cycle, it's difficult to even conceive. For couples who have normal regular cycle, the sperm is strong, everything is good, they even sometimes have it difficult to conceive. How much more someone who is having an irregular period? So anovulation or oligomenorrhea is the second part of the criteria. Now the last part of the criteria is ultrasound evidence of polycystic follicles or polycystic ovaries. Now on ultrasound, the sonographer will see some small follicles at the periphery of the ovaries, signifying that these follicles usually, if a lady is in the normal menstrual cycle and the lady is ovulating, after production of about 12 to 20 follicles, one of them stand out to mature, and that one follicle will release an egg, and that egg will go to the fallopian tube and to the uterus, that's the endometrium. If it meets a sperm along the way, fertilization okay. If it doesn't meet a sperm, then it comes out as blood. It shares with the endometrium of the uterus and comes out as blood as a menstrual period. But in the case of PCOS, the follicles that are produced, since they are not getting enough FSH hormone, that's a follicular stimulating hormone, they do not mature. So the 12 to 20 follicles will remain there in their dormant state. Then they will be filled with fluid, that is cyst. They will be filled with fluid at the peripheries of the ovaries. That is what will be seen on the ultrasound as polycystic follicles in the ovaries. So these are the three main criteria, but you need just two to conclude that this patient has polycystic ovarian syndrome. So the person may have a normal period, may have a normal cycle, but may have features of hyperandrogenism, that is treatment-resistant acne, hirsutism, together with polycystic ovaries on ultrasound. That person qualifies to be called a person with a PCOS or polycystic ovarian syndrome. The person may also have a normal ovary on ultrasound, but may have hirsutism and oligomenorrhea or anovulation. That person also qualifies to be diagnosed as PCOS. So you just need two out of the three to diagnose a person.
Okay.
So on the outside, as I said, you see that the person will have excessive production of hair, may have treatment-resistant acne, and in severe forms, we have something we call virilization. Virilization means that the person may have a deep voice. You see a female, when she speaks, the voice is like that of a male, together with the hirsutism, the treatment-resistant acne. It means it's a more severe form of hyperandrogenism. So when you see these things, irregular menses, hirsutism, acne, struggling with fertility, that is infertility, you have to draw your attention that now you have to see a medical doctor for further investigation.
Thank you so much, Doc. Very well explained. So I want to know, do we have interventions? What treatments are there? Can PCOS be cured? I want you to state categorically.
Yes, so there is a difference between treatment and cure. PCOS cannot be cured, but it can be treated. The symptoms can be managed. So we have 5 main principles in the management of PCOS. But before that, usually you get 3 classes of people coming to you with different symptoms. The first category of people will come to you that, doctor, I have bothersome symptoms that I would like to resolve. Another group will come that I want to give birth. So can you help me become fertile so that I can give birth? The last group of people will come without symptoms, without fertility wishes. They don't have any symptoms manifesting, but they have maybe ultrasound findings that they have polycystic ovaries. So depending on how the patient will present, you treat accordingly.
Okay.
So now back to the treatment principles. The first treatment principle is to induce ovulation, and that will go more for those who come to you with fertility issue. So we have medications that we give to such patients, and it induces ovulation in the patient so that the patient can give birth. The second thing is to stimulate periodic bleeding. Someone will be like, oh, why are you stimulating bleeding in someone with PCOS? As I talked earlier about the normal ovulation and menstrual cycle, I made mention that when the egg is released, the follicles produce sex hormone called estrogen. This estrogen thickens the endometrium, that is the inner line of the uterus, to receive a possible pregnancy, because the purpose of ovulation usually is to prepare the uterus to receive pregnancy. Now, in the normal person, if pregnancy doesn't happen, the prepared endometrium will shed away with the egg, comes out as your period. But since in someone with polycystic ovarian syndrome, there are a lot of follicles that are immature and they are all producing small amounts of estrogen. It means that the endometrium is being prepared, but no egg is released to be shed from the endometrium. So we will have something called endometrial hyperplasia. It means that the endometrium will be taken beyond normal. And if you have endometrium taken beyond normal, then it can lead to endometrial cancer. So in the management principle, you have to stimulate the bleeding.
Okay.
So that the patient will bleed and shed away the endometrium so that it doesn't become a hyperplastic endometrium and further lead to endometrial CA or
so in this case, they are unwanted.
Yes. So in this case, you stimulate the bleeding for the patient to bleed and shed away the endometrium to prevent endometrial cancer. In that case, we'll use combined oral contraceptives to help them to undergo the normal period. The third one is to control the hyperandrogenic features. So we have medication that will help the patient to reduce the symptoms of hyperandrogenism to reduce. So we give patients medications that will counteract the effect of the androgen. Now, the fourth one is for insulin sensitivity. There is this thing with PCOS where the excess produced androgens have an effect on the pancreas and also cause insulin insensitivity. So you will see that in most cases of PCOS, they have something we call insulin resistance, and that will later lead to diabetes mellitus. So they have DM type 2, basically the type 2 type of diabetes. So we have to increase insulin sensitivity so that it will prevent the patient from developing diabetes. So we give medications to counteract or to enhance the sensitivity of insulin so that the insulin can draw the glucose from the bloodstream to the tissues for the body to use. Then it will reduce the glucose level in the blood. Because people with diabetes, they have hyperglycemia. It means there is increased level of glucose in the blood. So if you have a medication helping the insulin to push this glucose from the blood to the tissues, it means the glucose level in the blood will be normal for the patient. So we give medications to enhance insulin sensitivity.
Okay.
And the last principle, that's the fifth one, is to prevent cardiovascular complications associated with PCOS. So usually if you have excess insulin in the system, causing insulin insensitivity in the system, causing diabetes, it turns around to affect the heart. And such patients in the long run will have cardiovascular issues, having heart problems along the line. So these are the main principles that we have in the management of PCOS. So depending on how the patient will present and what the patient wishes are, we will provide the appropriate treatment for the patient.
Oh, thank you, Doc, so much for the deep explanation. I want to touch on the insulin sensitivity. So does it mean that anybody that has the medical condition PCOS is at risk developing diabetes?
Yes, they are at risk. That's the correct word to use. They have higher risk of developing diabetes mellitus. So the thing is, there is this notion that people who are obese, like people who are overweight, definitely they have polycystic ovarian syndrome, but it's not entirely true. If you are overweight, it means that you have a lot of adipose tissue or you have a lot of fat cells. And fat cells also produce estrogen.
Okay.
Now you get where I'm going to. If they produce estrogen, it means it adds up to the already insulin that is produced in the ovaries by these follicles that are immature that we talked about earlier. That happen in people with polycystic ovarian syndrome. So if someone is fat or someone has a lot of adipose tissue, together with other signs of PCOS, then it means that this patient is at a higher risk of developing cardiovascular symptoms because the patient will produce estrogen. This estrogen will continue to cause insulin insensitivity. Then this patient will have diabetes mellitus. So it's like a vicious cycle. It goes round and round and round. So it's not anyone who has diabetes has PCOS, but everyone who has PCOS has a higher risk of getting diabetes.
Wow. Thank you. So, Doc, I want to find out after all these treatments, a woman gets pregnant, she's able to have a first child. And then she's struggling again, or she tries again for a second child, but does not get it. Does it mean that this PCOS condition is back and is affecting again? Also, my question is that once you have treated and a person get pregnant, does it mean they have now the condition under control that they can get pregnant at any time?
No. As I said earlier, PCOS can be treated but cannot be cured. So if for your first child you are able to undergo proper treatment and you deliver your first child, it doesn't mean that your second child will come automatically without struggling. You will have the same problem that you had earlier in giving birth to your second child because the condition is not cured. It was just managed for you to get pregnant. So the same way that it was managed for you to get pregnant, in that same way, it can be managed again for you to have your second child. But it's not automatic that once you give birth for your first child, you will definitely have no struggles in giving birth to your second child.
Very well understood. Thank you very much. So, Doc, I know there are a lot of women watching you who are also struggling with PCOS. Some of them need do's and don'ts. So, you have PCOS. What should you do to enhance your ability to conceive?
Yes.
And what shouldn't you do?
That is good. So the first thing you have to know is the first line of management of PCOS is lifestyle modification. Now, you have to change your diet. You should be eating more healthy. So you should be eating more of whole grains, more of fruits, vegetables. You have to avoid alcohol. You have to avoid smoking. You have to avoid eating fatty or junk foods. You have to build your body for the next steps ahead. So the first thing is lifestyle modification, have enough rest. And the most important thing is also exercise. Because we already talked about the situation where people with PCOS are at a higher risk of getting diabetes mellitus. And in the management of DM, lifestyle is the first. If lifestyle modification fails and dietary modification fails, that is when we switch to medication. So if you are able to exercise, so the exercise may include yoga, it may include swimming, cycling, not a very high intensive exercise per se, but something like swimming, cycling, yoga is okay for you to be able, for the body to be able to use the already existing glucose in the body, so that the body, you will not get fat. Then the body will not rely on the estrogen that is produced by the excess fat to go through another vicious cycle to impede on your fertility stance. So it's better to exercise, it's better to change your diet, it's better to have enough rest, it's better to avoid bad habits like smoking, alcohol, so that you'll be able to control or put the PCOS under control and get fertile easily.
Thank you, Doc. And then there are also some women who have gone to these treatments, but still to no avail. I mean, no child is coming. And they are only hanging on a thin line of hope. I'm just hoping that I'll have a child. So I want to find out from you, is it possible for every woman that has PCOS to have a child even after treatment?
So it's not 100% surety that whilst you undergo treatment, you will definitely have a child. And the treatment or the fertility aspect of PCOS is not a one-way street. It's a two-way street. Maybe the lady is going through everything possible. The lady is doing everything right, but what of the man? So the man, yes, the man has to also check the semen, go for a semen analysis, check for the morphology of the semen. Like, the man has to also undergo tests to see that he is also strong, he is also potent to be able to also deliver. So it's not always a problem of the female gender. It's also something that can also be related to the male aspect of things. Fertility in general is both sides, the man and the woman. So if they've been trying everything possible to get pregnant, it's not working, maybe the man has to also be examined. And PCOS is not the only thing that causes infertility. So whilst you are looking at PCOS, you have to also look at other things that could impede on your fertility aspect of life. So don't always focus on the PCOS aspect of it. If PCOS you've treated, nothing is working, probe further to see what may be causing the infertility.
Thank you, Doc. So I want you to, what advice you have for women out there who have PCOS, who are trying, who are undergoing the treatment that you outlined here, they are still trying. What message you have for them? What advice you have for them?
First of all, I'll give an advice to every mother out there before I come to people having PCOS. If your child starts complaining about irregularity in their menses, usually for adolescents in the early stages of life, they'll be complaining about irregularities in their menses, and that is normal for some of them. That would be normal in early stages of life, in the 13, 14, 15, 16 years of life. It's normal for them. But if this thing persists into the 20s and your child is complaining of irregular menses, sometimes the child misses her period, not that she's pregnant or she is on any oral contraceptive pill or has undergone any form of contraception, but complains of missing her periods, having irregularities in her period, it has to draw your attention that you have to seek help. Don't wait for your child to get married for her to undergo the struggles of having a child before you take action. In the early stages of things, take action. Now, to the ladies out there who are suffering from PCOS, there is hope. It's not a lost cause. You are not condemned to infertility. If you take up, the journey is a long journey. It's not a short one. So you have to be consistent. You have to gather up the courage. You have to be strong in spirit, because you undergo series of tests, series of labs before you can achieve your goal. So if you don't have the strength, the perseverance, and the consistency, it may be difficult for you to achieve your common goal, that is to have a child. So there is hope for everyone with PCOS. Once you are determined to give birth, I believe that there is a treatment for you to undergo for you to give birth.
Thank you, Doc. You're almost becoming a pastor. Thank you so much. So I want to also find out, there are some couples who have been declared medically fit, both man and woman, and according to their timetable, according to their expectations, their child, their giving birth is delaying, their childbearing time is delaying. Doc, what message you have for these people who have been declared medically fit? There is no problem, but their childbirth is delaying. What advice you have for them? What message you have for them?
So, first of all, we have to define what medically fit is. So, it can be that they are declared medically fit in the line of their sexuality, like the hormones that they are producing, the semen analysis of the man is good, the ovary count of the woman is good, everything is good. But we have other hormonal effects ongoing. Certain conditions or hormonal imbalances aside the ones affecting the ovaries may also cause infertility. So it's not that you've gone to the lab, you've checked your semen is okay, you've checked your reproductive system, the ovaries are in good condition, uterus in good condition, fallopian tube is patent. It's not only that, it's what we call medically fit. You have to be medically fit also in the regulations of the hormones that come from the brain to all the other parts of your body. Conditions like thyroid dysfunction also affect fertility, and there are more others. Congenital adrenal hyperplasia, a whole lot of conditions come together to affect fertility. So if you are declared medically fit, then it has to mean that you've done all these series of tests, you've checked your thyroid function, you've checked the function of other hormones in your body to see that there is no other thing impeding on your fertility. That is when you'll be declared medically fit. Now, aside that, you have to also time your sexual activity. You have to, usually the normal thing is to have sex when you are ovulating so that the sperm can meet a viable egg for you to get pregnant. So the timing is also important. It's not only that you are declared medically fit, you start having sex throughout the month, just like that. There has to be timing. And it also takes time. Giving birth takes time. There's also someone would say the spiritual aspect of things. But we, the medical professionals, we always talk about the medical aspect of things. So, medical wise, it takes time to get pregnant. It's not that you just go and have sex and you get pregnant. No, it takes time. So, if you're declared medically fit, make sure all other systems are functioning properly before you can say that you are medically fit to get pregnant.
Thank you, Doc. So there are some women who have tried everything and all hope is lost. I mean, they have given up. I can't have a child. And these people are being stigmatized by the society. This is what we call the infertility stigma against women, for which reason we have this interview. What is your view on infertility stigma? And what advice do you give to people who are engaged in that, who like to do it?
It's rather unfortunate in our society in this modern age. We have such a situation, especially in the family. You have close relatives telling you that you got married 5 years ago, you got married 10 years ago. Why are you not giving birth? Why are you not doing this? Why are you not doing that? It's very sad. In this world, no one came to this world with the intention that I'm not going to give birth. It's something that happened unexpectedly. It wasn't the will of the woman or the man to be impotent or infertile. So if you sit outside to stigmatize someone who is taking a long time to give birth, take in mind that it might happen to you. It might happen to your kid. It might happen to your grandchildren. So you shouldn't stigmatize someone who is having it difficult to give birth. I've encountered people who came to this earth not to give birth. They just don't wish to give birth. They don't want to have kids. That is their mentality. They don't want to have kids. So if someone doesn't want to do something, you can never force the person. Just respect the wish of the person. And we have other forms of giving birth now in this modern age. We have IVF. Just that is very expensive. We have surrogacy, we have IVF. So if you have the strength and the resources to go further, to attempt other means of giving birth, fine. There are so many options to explore. There is also adoption. If you've tried everything possible and you are not giving birth on your own, you can try adoption. People opt for that rather than even trying themselves to give birth. So there is no thing as stigmatizing someone with infertility issue. To me personally, it's very bad, and we must put a stop to it.
Oh no, thank you. I love this one. I love this one. So today I will say no to infertility stigma against women. And you know that women are the most affected people when it comes to infertility.
Exactly.
Even sometimes we had a case in Zimbabwe where a woman's hands were chopped off by her husband because I've married you for 5 years, no child. Apparently, he was the cause of the infertility.
Exactly.
And the man has been arrested, is in jail now. So thank you so much. You help us to see that it's not only the woman that can be the cause of infertility, but men too can be the cause. So together we say you should eliminate infertility stigma against women. Thank you so much. No stigmatization. Thank you so much. So my name is Emiliana Iliai, and this is one of my stories on ending infertility stigma against women. And I have been speaking with Dr. Gyedu Owusu of the LEKMA Hospital. Very resourceful, very intelligent. Thank you so much for your explanation, very deep ones. And even though there were big medical terms, I'll try to read more, but I understand clearly everything that you have said there. And I hope that the message will be out clearly that let us stop stigmatizing women who have not had children yet, according to your timetable. And as she said earlier, there are some people with a mentality that I won't have children. Do you know? You don't know. So if somebody does not have a child, you don't know why a person does not have, whether it has to do with a medical condition or their own mindset, their own desire not to have a child. You don't know. So please, as he said, help them with whatever resources you have, words of encouragement, be kind in word and action, and stop stigmatizing people. He said it could happen to you. Okay, you have your children now. It could happen to your daughter, your granddaughter. You don't know. So please, let us be kind and let us end all forms of stigmatization against women who are yet to have their own baby. Thank you so much, Doc.
Always a pleasure.
We are very grateful to you, and then we hope to see you again on our next.
All right.
Thank you. So my name is Emiliana Iliai. I'm a journalist, a gender advocate, one so much in love with women and children affairs. And I'm here to remind you to say no to infertility stigma against women.
My name is Gyedu Owusu. I'm a medical doctor. I'm here to tell you, say no to infertility stigma against women.
And together we say no to infertility stigma against women.